It's time for the Kim Hammer Show, where you'll learn how your state government affects you, your family, and community. Here's Kim Hammer.
Good afternoon. Hope you're having a great day. Thank you for tuning in to the Kim Hammer Show here on 101.1 FM The Answer. Thank you for joining me here today. We've got a couple great guests lined up for today. And if you want to get some further information, you can go up to the website at www.thekimhammershow.com. We will be posting some information after today's show that I think will be valuable for you. And that's www.thekimhammershow.com. Joining me today is Dr. Kent Corso. Actually, I've had Dr. Corso on the show several months ago, and we had a great conversation. I wanted to bring him back on because he is a highly recognized professional in the field, and we'll talk more about his credentials here in just a minute. But we're also joined by Representative Robin Lundstrum, a fellow colleague on the House side, which introduced some significant legislation during this past session. Get her opportunity to talk about that and some developing news related around that legislation that's coming out of Europe. And so, first of all, let me just welcome each of you to the Kim Hammer Show. Robin, thanks for joining us all the way from Northwest Arkansas. Why don't you tell folks, first of all, your geographical location and some of the areas you cover, just so they get an idea of where you represent.
Well, my district is 87. I have Springdale, Elm Springs, Tawnytown, and Siloam Springs. District 87, we joke up here, it's made in heaven.
Yeah, us down here might feel different. But anyway, okay. Now, Kent Corso, Dr. Kent Corso, why don't you introduce yourself and some of your credentials and tell a little bit about yourself just so the listeners can get an idea.
Great. Thanks for the brief intro. My name is Kent Corso. I'm a clinical psychologist. I'm a board-certified behavior analyst and a suicidologist, and I am calling in from the great state of Virginia. Prior Air Force veteran and officer, and that's where I got lots of my training and expertise doing research in the area of suicide.
All right, and suicide is not the most comfortable thing to talk about, but yet it is something you can't deny the fact that it is out there and that a lot of people struggle with it. So every once in a while, like to have a conversation about it because statistics seem to show that we're still dealing with suicide and the effects of it. So, Dr. Corso, let me just ask you, and just for the listening audience to kind of know where we're going to go with the Kim Hammer Show today, we're going to talk about suicide, but we're going to talk about it based on different populations and some of the specific characteristics that go with it. And one of the reasons I wanted to get Representative Lundstrum on the show today is because some legislation that she ran this past session and some of the accusations that were waged during testimony is that it would increase suicide rates among that population that we'll be talking about. Dr. Corso will enlighten us with some different perspectives and some facts, and so that's why I wanted to have Representative Lundstrom on. But then Dr. Corso going to want to talk as the show goes on. We'll let Robin drop off. She's got some other obligations, but we'll be talking about suicide among veterans. We'll be talking about suicide among high schoolers and just different populations in general. So that kind of gives you a direction of where we're going to try to go on the show today. Dr. Corso, let me just ask you, first of all, speak to suicide in general, not necessarily to any one certain population, but where are we as a nation in the direction that we're going with suicide, and are we improving, are we holding flat, or are suicide rates on the increase?
Okay, so just taking that sort of high-level approach for a minute, the bad news up front, and that is that there's never been a time in American history, Arkansas history, there's never been a time, in fact, in any developed nation where we have suppressed the suicide rate even by, let's say, 15, 20%, and then sustained that reduced rate. So I would argue we have better control from a public health perspective over COVID-19 than we do over the suicide problem. There are some years where we have a slight decrease, or maybe even 2 years in a row where we have a decrease, but we can't 100% say with certainty why it decreased, and we certainly haven't been able to sustain it. Suicide remains among the top 10 causes of death among adults. We have a little over 50,000 suicides a year in our country. And among children and adolescents, ages 10 to 18, it is the number 2 cause of death.
Oh, my.
What is it that, just give us a perspective, you being an expert in this field, give us perspective as far as what somebody is thinking, or what is it that gets people to the point that suicide even becomes a consideration in their life?
Senator Hammer, do you have about 3 days for me to answer that question?
Condensed into 5 minutes. So we'll find out how much of a professional you are. You got 5 minutes. Go ahead.
Yeah, right. That's right. Put me on the hot seat. That's perfect. So bottom line, suicidal thoughts, they are escape-oriented. People are feeling a incredible amount of pain. Sometimes that is certainly physical pain or related to illness or medical, but oftentimes it's emotional pain. And so it is just a very natural human response to not want to be in a tough spot, to not want to experience distress, to not want to have life be miserable. And so they think, well, what are some ways out of this? And so it's part of the problem-solving repertoire, but it's actually quite common for people to have what's called death ideation, or some fancy clinical jargon is non-lethal morbid ideation. I just kind of keep it simple, death ideation, right? And that's that idea of, wow, life is so hard, I just wish I didn't have to be here, or life is so difficult, I wish I were dead. Now, that's something that's actually quite common, but there are times where that grows into something like this. Wow, life is so hard, I wish I were dead, and I could see myself maybe causing my death or facilitating my death. And that's that second part that makes it much more risky. And that's where we are looking at suicidal ideation or suicidal thoughts.
So can you have Oh, go ahead.
Oh, go ahead, sir.
No,
go ahead.
Can you have a thought about death, but it not necessarily be suicidal? And what is it that distinguishes the difference? Because quite honestly, I think about dying. Of course, I think about dying, I'm going to get to go to heaven. So I look at it from a positive perspective, but that doesn't necessarily mean that I have suicidal tendencies. What's the differential? What's the difference between the two thought processes, and does one lead to the other, or is that just me having not enough coffee this morning?
No, whether you're on the right track, whether it's due to your coffee or your brain, sir. You hit the nail on the head. It's that people think of death all the time, whether it's hey, I'm looking forward to meeting my maker, or whether it's more of the negative angle, which is life is so unbearable that I wish I didn't have to live it anymore. And that sort of a death thought is actually quite common. And to your point, it doesn't necessarily lead to suicidal behaviors or attempts. It's when people start to take it a step further and they think of how they might play a role in making their death happen. That's when it becomes more risky, and that's when we call it suicidal ideation versus death ideation.
And are there things that we do you find in working with the folks that you do as an expert dealing with suicide, are there things that we do as individuals that prompt those suicidal rates, such as decisions that we make in life, or such as directions we may choose to go in life, or what is it that gets the pathway started?
We have known for at least 30 years that there are 7 common sort of triggers in life that will lead people to attempt suicide. The most common one is a relationship problem. Then right after that, substance abuse problem, a crisis that's about to happen in the next 2 weeks, or that has recently happened in the last 2 weeks. And then we have 4 other common, I don't really like the word triggers, but sort of they are life stressors. And that is a job or financial problem, a physical health problem, a criminal or legal problem, and then lastly, loss of housing, which actually happens in 4% of cases. And so we have these sort of common life stressors that make people so overwhelmed. And when they have this sense of hopelessness that they won't be able to either emerge and overcome this hardship, or that it's just so painful to be dealing with, that's when they have these thoughts of maybe it would be better if I were dead, maybe my family would be better off if I were gone, and they sometimes have this flavor of feeling like a burden to others. So maybe that's the folks with the substance abuse problem or the physical health problem. Maybe they think, you know what, My family has to take care of me, and I'm really in a fragile state, and I'm going to be this way for years because of my medical problem. I'm such a burden. Everybody would be better off if I were gone. So there are different flavors to this, Senator Hammer, depending on what the nature of the stressor is. One thing I do want to speak to that is commonly misunderstood is most people think about suicide as a state of indecision, a state of I can't decide whether I want to live or whether I want to die. And that's actually not true. It's not a state of being indecisive. It's actually a state of ambivalence. So suicide is feeling that you want to live and you want to die all at the same time. If we have time to unpack that, happy to do that. If not, I defer to you.
We might get, I tell you what, let's carry the conversation on. If we don't get that today, I'll get you back on, because one thing I wanted to do was take a look at some of the various segment of populations, because I know you work with different populations. I think you work with veterans, and I want to talk about like suicide among veterans, suicide among senior adults, suicide among certain populations, and have a down in the weeds conversation with that. But I want to start off with one because of conversations that have happened at the Capitol this past session, and it occurred in a committee meeting. And Representative Robin Lundstrum, who's on the show today, introduced some legislation about gender transformation and gender reassignment. And I'm not here to attack that population or be derogatory or anything, but one of the comments that was brought up was about it would increase the suicide rate if individuals were denied particular services or access to particular healthcare items. First of all, let's do this. Representative Lundstrum, explain what the legislation was, what it was intended to do. Just give that high-level view. And then, Dr. Corso, I'm going to come back to you, and what I want to ask you is this. What about the suicide rate in this population prior to transformation, reassignment, and afterwards? And let's have that conversation. Robin, go ahead.
Okay. Basically, what House Bill 1470 does is it prohibits sex change procedures on children. It protects children from gender reassignment procedures, both puberty-blocking drugs and cross-hormone or reassignment procedures as surgically and chemically. And then once they're 18, they can decide. The hope is that they will avoid doing this while they're going through puberty and won't have some of the long-term health implications, cardiovascular, cerebrovascular, the bone growth, all those things that they need to have during puberty just to be healthy. And then if they decide to make those decisions as adults, of course, we can't do anything about that, and that's their business. And one of the things that led me to run this legislation is just a sheer concern about what happens to these kids long term. And I'm so glad you're on the show today and can talk about these issues, because this is a serious issue with this population.
All right. So with that being said, and that being the overview, Dr. Corso, and I realize that in your profession there are probably differences of opinion, so we're not wanting to put anybody in a awkward way. But let me ask you: suicide rate among the transgender population prior to any kind of surgical procedure versus suicide rate after surgical procedure or treatment. Can you talk about the before and the after?
I can. It is tough, though. We don't have an incredible amount of data. Okay, so I'm going to speak with as much certainty as possible. I don't want to make any claims that aren't backed by science and fact and research. It is a fact that those who are struggling with sexual orientation, which is related, but it is totally different. So sexual orientation and gender dysphoria or gender identity, it is true that these folks may be at higher risk for suicide. Now, that doesn't mean we have data showing higher suicide rates. We certainly, as I said before, it is the top 10, it is the number 2 cause of death among children and adolescents. And certainly within the children and adolescent population, those who are struggling with sexual orientation and gender issues, it can be additional risk factor for suicide. I do want to be clear, one of the reasons why has to do with how they're treated socially. And we were all kids once. We know that there are growing pains during those teenage years and even in those middle school years when they're sort of tweens. They're not even teens yet. And so there's a natural developmental process that all humans go through in those tween and teen years, and it's about belonging. And where do I belong, and who am I, and how do I fit within the context in which I'm being raised? And those are hard times, whether you are having sexual orientation and gender identity issues or not, they're hard times. And so there is a risk factor that pertains to suicide around, it's called thwarted belongingness. It's either a really great Scrabble word or a really great tongue twister, but thwarted belongingness. This is the need to be a part of something, but sort of being shut out of it. And so that happens to teens in general, but then also if people are struggling with sexual orientation and gender, they might be sort of the butt of jokes. They might be treated with what's called macro or even microaggressions, where they're being treated unfairly just because they're different or because they don't fit. And that's where the greatest preponderance of science and research is that this is definitely a tough time for teenagers, but then if they're struggling with these issues, it's even tougher on them. I don't know of any research that says there's a higher suicide rate among those who are on hormone therapy or working up to a gender reassignment surgery. I am happy to read that research. If listeners know of it, happy to read more about it. I am a little bit persnickety here in that I do follow the science fairly closely. Mm-hmm. Now, by contrast, what we do know is that among adults who get the gender reassignment surgery, the post-surgical suicide rate is higher than the suicide rate of all surgeries combined. So if we look at bariatric surgeries, if we look at even surgeries like a mastectomy, a double mastectomy for women with breast cancer, what we know is that when we combine the post-surgical suicide rate of all those operations and compare it to the suicide rate among those of gender reassignment surgery, the gender reassignment surgery post-suicide rate is higher than all the others combined. And that's what, from a scientific perspective, has to make us pause and look a little closer at this issue and not just sort of take leaps and bounds to just kind of go with the flow. If people are dying after the surgery, we need to figure out through science and research exactly what's happening.
What do you think? Go ahead, Robin.
What about the suicide rate for those that just go with the hormone treatment? In that population, for one I'm reading, that's still a 19 times higher suicide rate.
So I'll be honest, Robin, I haven't seen those data.
Are the numbers commingled? I can't find it separated out either. I don't know if it's surgical or if it's because it's chemical. So
yeah, I don't know. So here's the problem with suicide data. So I'm a total data dork, so apologies in advance. But suicide, when we compare it to the overall population, the statistics make it very hard to work with. So, for example, even the Centers for Disease Control, they only aggregate their suicide statistics every 3 years because they want to make sure they have enough statistical power, enough data that they can say, hey, this is really happening, not, oops, it's just a coincidental change in the numbers. And so if we can't even make predictions and conclusions around our suicide data at the national level, but every 3 years, I don't know how we're able to make it with such smaller numbers with these special populations. And frankly, we're not. I think even the data on veteran suicide, we have to aggregate it across all wars ever. So we're looking at from the Korean War to present. Certainly we have some World War II vets who may be still alive, but we're looking at aggregating those. We don't, it's a little fuzzier science and fuzzier math to say, okay, let's look at the Gulf War suicides versus post 9/11 suicides versus Vietnam suicides. The numbers are just smaller, so we don't have as much certainty.
Let me ask you, Kent, why, from a professional point of view, why is the rate higher after the treatment or after the surgery than before? What is it that creates the higher numbers?
So it's a good question. The easy answer is the science. We don't know yet. The science hasn't figured it out. I can say from working with the LGBTQ plus population myself, working with people who have pursued the surgery, working clinically with them, it's a very tormenting issue for folks to struggle with. I mean, there's no other way to say it than that. These folks are in a lot of distress. They feel like a fish out of water. They feel like they were born into a body that doesn't really meet their physical body, and how society treats them doesn't really match how they feel on the inside. And so whether they get hormone treatments or surgery, even before any of that, folks with gender dysphoria, there's a lot going on internally in terms of difficulties and challenges. So if I were to make a guess as to why the post-surgical rate is so much higher, it's because I think, and again, please understand this, we don't have the data yet, this is just my judgment, but I think it has to do with adjusting to roles and adjusting to societal norms that are not something that they were born into. I think it has to do with adjusting to a lifestyle. The sexual organs that if they do that gender reassignment, the sexual organs are somewhat functional, but not fully functional. Also remember that while their genitals may be different than what they were given at birth, their chromosomes are still the same, right? So XY chromosomes in males and XX chromosomes in females. And so this is a very complex thing that we talk about gender reassignment surgery, but we're really changing the genitals, and we're changing some of the physical characteristics that, of course, pertain to gender, because gender also has a social aspect to it. And so think about changing your body on the inside, changing your body on the outside, having society treat you differently based on what they're seeing in that body. And there's just a lot of room for stress in all of that. That's probably the best way I can say it. I wish I could say it in one sentence instead of 10.
Robin, you got anything you want to ask or weigh in?
I just that's a lot of conflict to go on in for one person to handle.
I guess what I'm wondering is, how do you counsel somebody that comes in after the fact? And if the rate is higher, suicide rate is higher after the procedure, what do you do in the way of counseling in order to help somebody that has had that life-altering surgery or change that, for all practical purposes, I guess can't be reversed? So now they've got to live with the decision and the consequences of the decision. How do you counsel somebody to help them not seek suicide as the solution?
That's a hard question. It's a good question and a hard question. I think what I would say, Senator Hammer, is there are times in life where we can't unscramble the egg, as they say, right? So whether I have been a sexual assault victim, whether I was exposed to trauma on the battlefield, whether I was beaten as a child, there are life events that happen in our past that we can't go back and change. And so any of the research that pertains to how we overcome those sorts of situations, I think, would be the most appropriate. There is something called acceptance and commitment therapy, which is gaining more and more data behind it as a very powerful form of counseling and therapy. I think, of course, if we are finding out that the person is having suicidal thoughts, we have to use the most evidence-based treatments for suicide and the best ways to assess the risk. I won't bore your audience with the technical nitty-gritty, but we have to make sure that we are a genuine, supportive, caring clinician in how we treat these people. I can share with you a case that I treated a few years ago. I have to change, of course, some of the demographics for the confidentiality of the patient, but this was a...
Hey, let me interrupt you. Let me interrupt you.
Go ahead. Go ahead.
Robin, can you hang on, or you got to go?
Yes.
Okay.
No, I'm good.
Okay, so I've got to take a break. Heidi's giving me that look, and this will, I think, be something that you want to come back and listen to. This is Kim Hammer, and you're listening to the Kim Hammer Show today. My guests are Dr. Kent Corso and State Representative Robin Lundstrum. We're talking about suicide among various populations. We'll be back in just a minute after the break. Welcome back to the Kim Hammer Show. Thank you for joining me here on 101.1 FM The Answer. If you're watching on Facebook Live, thank you for joining here on the Kim Hammer Show. My guests today are Representative Robin Lundstrum and also Dr. Kent Corso. And thank you all for being on the Kim Hammer Show today. And Kent, you were about to tell us a story, change the name of the identity, obviously, for HIPAA reasons. But go ahead and share the story if you would.
Sure. So this is about a 60-year-old man. He was born a man, had come into treatment with suicidal thoughts, and many of the suicidal thoughts revolved around his journey over the prior 20 to 30 years of struggling with his gender identity. And so your question, Senator Hammer, was around how do you help people post-surgery? This particular person was pre-surgical, was living as a woman for years, had gone through all the hormones, was using women's restrooms, was wearing traditionally sort of female or feminine clothing, and got ready to do the surgery. And then something with inside of him said, you know what, I can't go through with this. And over the course of therapy and counseling and treating him, it just became clear that he had such indecisiveness, but then also ambivalence. He felt many masculine things and many feminine things. And I think actually the idea of making that permanent change to get the gender reassignment surgery, that is something that rattled him. And he really had a hard time with this idea that I might be doing something that's irreversible. And so in considering that, I think then he questioned, well, what the heck have I been doing for the last 20 to 30 years? And that's where the suicidal thoughts came in, is just this idea that I'm 60 years old. I don't even know who I am. And gosh, I should know who I am by this time. And so I use that as just a very tangible example of how challenging these issues are, and how we really do need more research to understand why the post-surgical suicide rate is so high. Just working with that particular patient in a pre-surgical sense, his suicide risk was pretty darn high.
Would it be
and he hadn't even gone through with it.
So would it be fair to say, while it is that we don't have the research that has determined why, we do have the numbers that support that it doesn't necessarily solve the problem through the surgery, that it might actually complicate the problem? Is that a fair conclusion, or what would be your response?
I think that is a great tentative way to look at it. The science as a field says that every conclusion is temporary, right, until we further our science and develop a new theory and prove it wrong. And so I think it is reasonable to say that it is such a complicated problem. And if there wasn't a post-surgical suicide rate that was so high, then perhaps we say, well, we have enough data to keep moving forward full steam. But because of that post-surgical suicide rate being higher than all other surgeries combined, we've got to tap the brakes and start to look a little closer at what's happening, if for no other reason than to protect the people who are going through these procedures.
Which I think is what Robin legislation was all about. It was introduced from the perspective of not necessarily punishment as much as it was protection. Is that fair, Robin?
That's completely correct. That was the whole goal. They're children. Let's get them to adulthood, and hopefully they can make better decisions regarding their health, because this can be permanent, obviously.
All right.
So, I had a question for the doctor on gender-affirming counseling. We keep hearing how this is so wonderful, but in my mind, it seems to be so counterintuitive. You wouldn't put an anorexic in the counseling chair and say, oh, yes, you're fat. It seems like we're not giving somebody coping skills and the skills that they truly need. What would be better than gender-affirming counseling?
The easy answer is we don't know. Gender-affirming counseling is what I think the mental health field has led with to try to follow their ethical mandate to do no harm, so beneficence and non-malfeasance. But the reality is there isn't a great bit of data. There aren't numerous randomized control trials or other high-quality research studies showing that gender-affirming counseling is the gold standard and is highly effective and minimizes all costs while maximizing all benefits. What I will say is it's sort of the best thing the field has come up with. You mentioned something about putting someone who's anorexic in a chair and it sounds like helping them affirm that they should be underweight. You might be familiar with Dr. McHugh out of Johns Hopkins University, who professor of psychiatry at Johns Hopkins School of Medicine, who has compared gender dysphoria to anorexia. In other words, subjectively on the inside, someone with an eating disorder may feel fat, but the objective medical data shows that they are not. And by contrast, or by comparison, someone who says, I feel like a woman inside, even though I have XY chromosomes and I have a penis and testicles, I feel like a woman inside, the objective medical findings would say, well, but you're not a woman inside. And so I think that may be where, if any of the listeners are kind of scratching their heads about the relationship between the gender stuff and the eating disorders, it's the work of Dr. Paul McHugh. And it's an interesting point. I mean, it's an interesting point from a scientific perspective.
Let me ask. Go ahead, Rowan.
Go ahead.
No, go ahead.
I've just wondered why we're not helping these kids with coping skills and helping them work through gender distress and the gender dysphoria issues, since it's obviously they need help. And giving time and support, most of the kids will reaffirm with the gender that they have if they're given the support. It seems like they go to the doctor and they're pushed, almost rewarded and pushed. Oh, yes, you don't fit in, so we're going to help you not fit in, or we're going to help you go in this particular direction, instead of helping them feel good about the body that they're in. We're almost doing the opposite. It's confusing to me that we would do that.
Yeah, I hear what you're saying, Representative Lundstrum. The way I try to think about it is, bottom line, we don't have research that really says either way. So we do have to have some level of pause there, but certainly we don't want to put people in a circumstance where they can't unscramble the egg, they can't go back, they make permanent decisions, permanent changes. If we had one thing I like to think about to try to help keep clear sight of this is development, right? What is happening to children pre-puberty and during puberty, and not just physically, what's happening emotionally. And so if I had a 5-year-old child, go ahead.
And mentally, yeah.
And mentally, absolutely, cognitively, cognitive development. So if I had a 5-year-old child who says, I don't like sharing and I'm not going to share, and oh, by the way, I like eating dirt because it feels good and tastes good, would we encourage that behavior? And would we encourage kids not to share? So that's one question. What would we do? The other question is, what are the consequences of just blindly following a child's impulse and sort of reinforcing that and cultivating that? If we were to, let's say, just take the stance of I don't like to share, and I think being selfish feels good, and so I'm going to do it. And so we say, okay, well, let's support you and let's affirm that and keep doing that. Is that consistent with? Is that a good idea? Is that consistent with being a highly functional adult? I think that's something that may not have anything to do with the gender, but where the tie is that we program our children. I know we like to really say that feelings are important because, frankly, they are, and it's important to validate children. But when your child says, "Dad, I think I can fly. Let me go try to jump off the roof," you can bet I'm not giving him a cape and telling him to try. Right? And so how we cultivate, how we reinforce, how we encourage things that our children say absolutely fuels it. We are literally programming them. They only create the world that we help them create. And so we just have to be careful if we don't have enough research in one direction or another before we tell a 2 or 3 year old that, oh, I know you were born a boy, but you feel like a girl. Okay, then let's just blindly go there. It seems irresponsible, and it seems to underappreciate how much we are, I'm going to use the word, programming them.
You don't have to respond to this, but as I was listening to you talk, and you use that phrase, do no harm, and in the absence of hard evidence, because we just don't have enough evidence yet, how could a medical professional recommend a procedure in the absence of adequate evidence and not be doing harm to that child by directing them or the parent of that child who may be encouraging that child? How could we not think that or draw the conclusion that they may actually be doing harm because there's not enough evidence yet to support it?
So I think it's a good question, sir. I think we have to be careful. There isn't enough evidence to say that we are doing harm. Yes, there's the post-surgical suicide rate, but we still haven't teased out what that's all about. So there are cases where people have gone through the full transition and they're living very fruitful, happy lives. So again, it's a tough one. It's certainly, the whole issue is sort of different than history would write itself, right? It's different than the way things have gone 50 years ago, 100 years ago, even though we do have examples from ancient Greece of people trying to remove their genitals. This isn't just some anomaly that happened in the last 20, 30, 40 years. It's just that we don't know enough about it in either direction. I don't know if we can say we are unequivocally doing harm by supporting people. I don't know that we can say that either.
Okay. And the second thing is, how much is society and the direction that society is going contributing to the issue? For example, back when I was a kid, you had 2 choices, and the idea of a third choice was not even really in the social circles to be talked about. How may it be that society, including the counseling that people are given or the advice that people are given or the contribution of the educational system to the conversation, how is it that society is contributing to this issue?
The best way to answer that, sir, is that I think we have a little bit of a misfire in our heads, and then I think when that happens to numerous people in a group, it sort of becomes more of a social pattern. We have this idea that if something's more common, then it makes it more right. And I'm using air quotes. You can't see me, but I'm using air quotes around the word right. And so the more we learn of school shootings, the more we become, I guess that's just the way it is. The more we learn of someone getting carjacked and I'm using crimes as an example because I think with the way with the internet, with the way the media works, we have so much access to so much information. And so I think just information access leads us to believe that, if this is happening more and more often, this is, quote, normal, or this is right, or this is the way it should be. And I think that's where there's a bit of a misfire, just because, for example, I have a teenage daughter. I am very dialed into everything going on in her social context. And it's common for kids in her class to say, yep, I'm bisexual. I like both men and women. And it's like, okay, well, whatever. Okay. If that's what's going on, I'm not going to judge it or say anything about it. But the more they tell each other, the more people voice that they are the same way. And so there's this social thing we do that the more we hear about something, the more we identify with it, the more common it becomes, the more likely we are to sort of flirt with that idea. And so I do think that that's what's happening at a societal level, is this sort of like awareness is so important, and awareness of our differences and our similarities and diversity, equity, inclusion. I have to say that stuff is critical. It is so important to be aware of each and every one of our uniquenesses. And at the same time, what we have to be careful of is to not believe that just because something becomes more common or I become more aware of it, that is sort of the standard that we should be achieving or shooting for. I could probably go off into all sorts of different directions, but I'll stop there, and hopefully I answered your question.
Well, you did, and I guess I've got a friend who's, a teacher, and one thing that has been shared with me is that the tendency is that, yes, some of it would be considered attention-seeking, and sometimes when a member of the opposite sex begins to pay them attention, those tendencies go away. That's not professional opinion, that's just personal, lifelong observation in the classroom, is that when they are given attention from members of the opposite sex, that actually drives them away from those thought processes or those tendencies, because now they're getting that attention they weren't getting before. Do we, as a society, have a problem with teaching people to accept themselves as they are and helping them in the state of which they were created, instead of trying to give them alternate routes out? If you want to answer that question.
I don't know if I can speak for society. Okay. Does society do that? I think I would say that I think it depends on your belief system, and that's I think the biggest underpinning around this whole issue is folks who are much more faith-based. I think folks who are less, in contrast to folks who are much more progressive, or even less faith-based, you've got beliefs playing into this entire issue. And that's where, as a scientist, I get concerned, because we should really be following facts and science and in my opinion, just my opinion, not relying on our beliefs and our own opinions. So it makes sense from a scientific perspective that if someone gets attention from the opposite sex, that maybe they gravitate toward that specific person or that gender. That makes perfect sense. That doesn't mean, though, that they're not still confused inside, or they're not still feeling something inside that's sort of in turmoil.
Okay.
So they're not mutually exclusive, right? I mean, one doesn't mean the absence of the other. It's likely that both things are possible and happening at the same time. Right. So getting attention, I'm going to use a deeper word, is they're getting validation for who they are and how they look and how that person connects with them. And that's very powerful, to have that validation. All
right, Robin, you got anything you want to ask or add to it?
Well, no, I'm enjoying the whole conversation. It's been great. I did want to let you know one issue that's popped up just in the end of April, just to wrap this up. Sweden had issued a new policy regarding the treatment of gender dysphoric minors. And Gender Services Division at their leading hospital, basically they're ending their practice of prescribing puberty blockers and cross-sex hormones for minors under the age of 16. Because of, just as we've talked about, they felt there was significant risk, there was uncertainties in the hormonal interventions, and wanted to wait till the minors had a maturity level and ability to understand the long-term consequences, calling this a watershed moment in Sweden's health industry. And they want to explicitly stop their Dutch protocol, is what they're calling it. So realized they were starting the puberty blockers at age, and they were starting to increase this as young as 8 or 9. And so anyway, they just felt out of abundance of caution that they needed to stop that program. I'm sure it's going to end up in their courts. But they also, in this article, they also talk about Sweden is revising their guidelines as well when it comes to adolescents, just out of an abundance of caution that this seems to be something that's not a good idea for adolescents.
Representative Lundstrum, what article is that, ma'am?
And this, I don't have the whole thing in front of me. I just have some notes, but it was put out, I think the National Health Service was part of this. I'll
Got it.
Pull it all.
Just curious.
I can screenshot it and send it to you.
Thank you. Yeah, I'd love to read it. Thank you.
Yep. So it's evidently other countries are starting to weigh in, and this was right after the British High Court had theirs, and I think other countries are looking at their policy as far as this is concerned.
Which they're way out ahead of us as far as having allowed this longer than what we have here in America. Is that right, Robin? Seemed like I remember you testifying to that.
Mm-hmm. They are, and but this is something that I was just reading about this just the last couple of days and thought, oh, wow, I've got to dig into this more and see what led up to this.
Okay. Tell you what, if you'll screenshot that, send it to me, or I'll get you Dr. Corso's number, and then we'll get it up on the website so people can go up there and look at it and read it as well. All right.
Okay.
I'm down to about 7 minutes. Let's shift gears just for a second, Dr. Corso, to finish up our time. You mentioned 7 areas a while ago: relationship, substance abuse, crisis, plus or minus 2 weeks either side of the crisis, job and financial, criminal, loss of housing, and there was one other one I can't read my handwriting on. Those are the 7 top areas of which suicide occurs in. Is that what you said?
Those are the most common stressors that drive people or immediately precede a suicide attempt.
And as far as which area it relates to, whether that be somebody that is a veteran, a senior adult, maybe realizing they don't have enough income to make it to the end of life, as far as the areas or the categories where suicide rates are the highest going to the least, are those numbers broken down out there somewhere?
Yes, it's actually drawn from the CDC's National Violent Death Reporting System.
So give me the start. Go ahead. I'm sorry.
Yeah, so I'll start from the top. You want the percentages?
Yeah, just start at the top and work your way down.
Perfect. So 42% of suicides were preceded by a relationship problem, 29% a crisis upcoming or in the prior 2 weeks, 28% substance abuse, 22% physical health problem, 16% a job or financial problem, 9% criminal or legal problem, and 4% loss of housing. There are other events, of course, too, but they're below 4%.
The relationship, such as what? Give an example of what you talk when you say relationship. What do you mean?
Typically, it's an intimate relationship. So whether it's 2 partners, 2 unmarried partners, whether it's spouses who are married, that's the relationship problem. It's typically not like a friendship. It's usually a romantic relationship or intimate relationship.
And in that area, when people exercise suicide, do you know, are there statistics that show it's more of a revenge factor, like I'm going to show you, versus they're just at the end of the road and they use suicide as the option out?
No, it's not about revenge. If it is, it's a very, very small percentage of cases. It's about feeling alone and lost and not being able to cope. It's about feeling lost, to be honest. What we know about suicide is one of the most common denominators that people experience when they are thinking of killing themselves is a loss of meaning and purpose in life. And frankly, that's why, in my opinion, the veteran suicide rate is so much higher. Is because when people join the service, they have strong sense of meaning and purpose, and they have a unit or a group of people around them who are their support system. And when they get out of the service, they don't have as clear of a mission, and they lack that same unit. And so, so meaning and purpose in life, but then also let's bring in just that concept of belongingness. that we talked about earlier in the program today. And the fact that when people have the need to belong to something and don't feel like they belong, whether it has to do with their gender, whether it has to do with their sexual orientation, heck, whether it has to do with the race, or veterans, right? So if you don't feel like you belong to something, that's a pretty lonely place to be. And they question, what's my purpose? Why bother living?
So what do you say to somebody that's lost their identity because they've lost their relationship or their house or those things? I've got about 2 minutes left. What do you say to somebody to get them to redirect their thoughts away from suicide to the value of living life?
It's a process, but I ask them who they were before that relationship. Just because they're in a relationship doesn't remove or divorce them from who they were and what they brought into that relationship. And so ultimately what we know is that the more we can get people talking about their reasons for living, the less likely they are to have severe suicidal thoughts and to attempt. And so it's a process, though. It's not talking people out of it. Telling people you have so much to live for does not help. It's getting them to think through, what is my meaning? What is my purpose? What do I have to live for? And getting them to sort of struggle through the difficult stuff in order to pursue those reasons for living.
All right. I'll tell you what, I'll get you back on because we spent the majority of our time talking about the one subject matter. There's some other things I'll get you back on in a month or so. I did have the opportunity to meet Dr. Corso. We've corresponded. I've had him on the show before, but he was in Little Rock about a month ago. And Dr. Corso, great to meet you. And I thank you for taking time to be on the Kim Hammer Show. Any final words in 15 or 20 seconds?
Just thanks so much. Pleasure to be here.
Thank you. Robin?
Thank you, Dr. Corso. It's a pleasure. I enjoyed just listening, and thank you so much for all you do.
All right.
You're welcome, ma'am.
You've been listening to the Kim Hammer Show here on 101.1 FM The Answer. You can follow at my website, which is www.thekimhammershow.com. The bill that Representative Robin Lundstrum was referencing was House Bill 1570. Did you get an act number on that real quick, Robin? Do you know what the act number is?
No, not off the top of my head, but it is officially an act.
Okay. House Bill 1570. You can go up to the website and track it there. All right. Thank you for listening to the Kim Hammer Show today. I hope that you feel better informed and that you are better educated as a result of the time we spent together. Look forward to being with you again next Saturday here on the Kim Hammer Show on 101.1 FM, The Answer.